Well, good morning, ladies and gentlemen. I think this is truly a defining time in our approach to the diagnosis of early prostate cancer. Congratulations to Dr. Kazi, Dr. Moore, Dr. Emberton, and international colleagues for completing this truly practice-changing study. I truly believe that what you've just heard will fundamentally change our traditional approach to the early detection of prostate cancer. Let's remind ourselves of what we've just heard. This is the control arm of the precision study, an at-risk population suspected of having prostate cancer who undergo the traditional diagnostic paradigm, which is a systematic prostate biopsy. And what does this lead to? It leads to a detection rate of clinically significant cancer of 26% and a detection rate of clinically insignificant cancer of 22%. Let's look at the control arm of the study, the image-guided arm. In this arm, all patients underwent an MRI scan, and in those patients in whom the scan was normal, they avoided a biopsy and had routine follow-up. And this is 28% of patients in the precision study. In those patients who had an abnormal MRI scan, they underwent only a targeted biopsy of the lesion, and a systematic biopsy was avoided. And the outcome of this is an increase in the diagnosis of clinically significant cancer of 38%, including those patients who didn't have a biopsy, and a decrease in the clinically insignificant rate of 9%. So fundamentally, I would propose to you that this is very good news for our patients. What we see here is a significant proportion of men avoiding a biopsy altogether, much less core involvement, therefore much less complications, more significant cancer diagnosed, and less insignificant cancer diagnosed. Undoubtedly good news for our patients. However, I can sense the anxiety in the room. This is the part of the study that fundamentally makes some of us a little nervous. What's the outcome? What's the fate of these patients who did not undergo a biopsy despite having a clinical suspicion of prostate cancer? But of course, we already have the outcome of these patients from the same study group led by Mark Emberton, who last year read out the PROMISE study and published it in The Lancet. And we know that this group of patients who have a normal MRI have a 1 in 4 chance of having some pattern 4 cancer on the biopsy. So I think that's what we have to digest if we're going to fully embrace this paradigm. And I would propose to you that rather than just have the routine follow-up that's been proposed or described in the precision study, I think we need a slightly more sophisticated approach to this at-risk population despite the MRI being abnormal. And I think looking for traditional red flags based on family history, PSA parameters, etc., might lead me to propose that there is still a role for systematic, in my case, transperineal biopsy for a select group of patients within the normal MRI cohort. I would like to also congratulate this study group on the pragmatic study design that Dr. Kazi has just outlined. This is very important. This is not academic centres. This is not high field strength magnets. This is not predefined sophisticated biopsy techniques. It's not even defined how the lesions are targeted. It can be visual targeting. This has led to the rapid recruitment, but also very importantly for all of us in the audience, it means that the real world today generalizability of this fundamental paper is immediate. It applies to all of your centres around the world. So I think this is the take-home message. I think we have heard the new paradigm today, and I think we should embrace it. The combination of the PROMISE study published in The Lancet and now the precision study published in the New England Journal of Medicine mean that we should fundamentally embrace this new paradigm of bringing MRI fast forward to the diagnostic pathway prior to biopsy. And I would agree that I think everyone should have an MRI, if possible. And I think there is a role for targeted biopsy only. That's something I wouldn't have said before today. But I now believe that in those patients with visible lesions, we can afford to only target the lesion.